At the outset, I'd like to thank the organizers of the Department of Pathology for organizing such a wonderful endopathology symposium. And I'm sure this will be of great benefit to both the endocrine surgeons and the pathologists. So let me share my screen. The task that has been given to me today is to talk and share with you about the diagnostic workup in adrenal lesions. Now, adrenal lesions mostly present as an adrenal incidentoma, like many other endocrine organs. And as per definition, they are clinically inapparent adrenal masses, which are inadvertently detected during a non-invasive imaging studies, particularly a CT scan, which have been conducted for reasons and symptoms other than for the evaluation of adrenal glands. Now, why is it important that we talk about adrenal lesions? Particularly adrenal incidentlomas. Now, these lesions may be hormone secreting, but they may be silent without any symptoms. For example, a normotensive pheochromocytoma, and you have a time bomb sitting there, which can burst anytime or during any other unrelated surgery. Similarly, a steroid-producing adenoma can be potentially harmful, even though there are no symptoms overtly present in the patient. Other important concern is that they may be harboring malignancy, and it is very difficult to predict whether a particular lesion is going to be malignant. Though size and Hounsfield unit are the criteria which help the clinician to predict malignancy to a certain extent, and I will come to this later in my talk. There are a couple of controversies surrounding the management of adrenal lesions, whether one should operate on all adrenal lesions or should a conservative management be followed in selected cases. Is there any benefit of adrenalectomy, particularly in patients who have subtle symptoms like a subclinical steroid-producing adenoma? And what should be the follow-up protocol once these patients have been either operated or put on conservative treatment? And I'll touch upon these controversies later in my talk. Now, one should remember that the majority of these adrenal lesions are non-secretory. And in one study, it was found that 85% of these lesions were non-secretory, followed by subclinical Cushing syndrome, pheochromocytoma, and aldosterone-producing adenoma. Now, this is a slightly older slide. I mean, it's almost 2 decades now. But recent studies, and even one of our own studies, have shown that amongst adrenal incidentlomas, which are hormone-producing but silent, pheochromocytoma is the commonest. And in our studies, in fact, it was around more than 40% cases of adrenal incidentlomas were actually pheochromocytoma. You can see the importance of workup of an adrenal lesions for hormonal production, even though they are silent. And imagine if these pheochromocytomas were missed or patients were operated for other unrelated conditions, they would have a hypertensive crisis during surgery. Now, most of these lesions may be non-functioning and indolent and asymptomatic and may not cause harm to the patient. But as I mentioned, the high proportion of these tumors will be subclinically functioning and they may be potentially harmful to the patient. So I'm overemphasizing this point for the benefit of the listeners. Initially the fear was that we may not miss any malignancy in an adrenal lesion, but now there is more fear of missing a subtle function which is potentially harmful to the patient rather than missing malignancy. And I would say, in fact, both of these reasons are important to work up adrenal lesion. Now, what is the endocrine workup which we normally do in our practice is that, first of all, as a general principle, the adrenal incidentlomas should be screened for adrenal catecholamines, all adrenal lesions, except recent data has shown that in cases which have a low Hounsfield unit, for example, minus 40, minus 50, where the CT diagnosis of myelolipoma can be made, you can exclude doing an adrenal catecholamine estimation. And again, patient having overt glucocorticoid excess symptoms and signs, one can exclude doing adrenal catecholamine. But in my practice, I'll probably do catecholamine or metanephrine estimation for almost all adrenal lesions. Now, any patient who has hypertension or hypokalemia, of course, mineralocorticoid excess should be excluded. Similarly, any patient of adrenal lesion along with hirsutism or valorization should be suspected of either androgen producing or estrogen producing, or even mixed cortisol androgen producing, which is a hallmark of a malignant lesion. Now, a couple of points specific to specific adrenal lesions. Screening for primary aldosteronism. One should remember that hypertension and hypokalemia are the major classical clinical findings. And then whenever you get them in the context of an adrenal lesion, they should prompt the clinician to carry out appropriate screening investigations. But remember that PA is associated with low plasma renin activity because the aldosterone-induced hypervolemia results in suppression of the renin release. Now, why should we work up a lesion which is suspected of aldosteronism? Because there is a high chances of stroke, coronary artery disease, fibrillation, heart failure, and even mortality when you compare to matched population with essential hypertension. So there is no doubt to my mind that all lesions where you suspect a primary hyperaldosteronism, they should be worked up and managed, either treated surgically or medically. So the diagnosis of PA is important and requires either surgical excision or a targeted antihypertensive therapy with mineralocorticoid receptor antagonists. Now, although I'm aware that this is not a topic for the to talk about in detail about the workup, hormonal workup, but it will be interesting to know that there is a three-step approach for the screening, confirmation, and subtype classification for a lesion suspected of primary hyperaldosteronism. Now, the most reliable means for screening is the aldosterone-renin ratio, whereas a lot of confirmatory tests available, but in my practice, my endocrinologist would do a oral sodium or even a saline infusion test. But fludrocortisone suppression test and captopril challenges tests are just mentioned, but not routinely carried out. The third aspect is how to confirm that whether it's a tumorous PA amenable to surgery or it is a bilateral hyperplasia where medical treatment is a treatment of choice. And for subtyping, I commonly use a CT scan, which is helpful in majority of cases, and sometimes MRI. But AVS is a very informative investigation, though it is invasive. But in patients who have a CT scan which is equivocal or it shows a bilateral lesion, AVS or adrenal venous sampling is a very good investigation, though it requires a certain level of expertise and is done in specific major centers such as SGPGIMS. And of course, the new kid on the block is the metomidate positron emission computed CT scan, which is quite helpful in picking up the adrenal or bilateral disease. The third lesion is usually the sex hormones or sex steroid secreting adrenal lesions, and they may be either androgen producing or they may be estrogen producing. So in women, if there's androgen secreting tumor, there may be features of virilization, such as excessive facial hair growth, skin changes, whereas estrogen secreting tumors in women will cause breast tenderness, irregular uterine bleeding, whereas in men, the estrogen secreting tumors may cause feminization, such as decreased libido, testicular atrophy, and gynecomastia. And once a patient presents with these features, the estimation of sex hormones or 17-hydroxyprogesterone is the investigation choice. Now, to summarize, for screening, we have to exclude a cortisol-producing adenoma by a low-dose dexamethasone suppression test, a pheochromocytoma by a serum plasma metanephrine or a 24-hour metanephrine and non-metanephrine. For PA, we have to do either a plasma aldosterone-renin activity or ratio, which is as a good screening test. And if ACC is suspected, you can do a DHEAS or a low-dose dexamethasone suppression, and I will detail it in my subsequent slides. Coming to pheochromocytoma, it's always a question that is asked, which is better, a plasma-free metanephrine or a urinary metanephrine, non-metanephrine. In my practice over the last 25 years, our endocrinologists are very happy with urinary fractionated metanephrine, non-metanephrine, which gives excellent results. But the plasma-free metanephrine is, of course, found to be more sensitive as compared to the urinary metanephrines, but it's quite expensive, not easily available. We don't do it. but I found that it is useful in hereditary syndromes as compared to the sporadic ones. So when I get a hereditary, I like to do a plasma metanephrine, whereas in rest of the cases, I would like to do a urinary metanephrine, non-metanephrine estimation. Hypertension is the commonest sign of pheochromocytoma, but remember 30% of pheochromocytomas can be normotensive, silent, and they can be easily missed. Now coming to another very interesting entity is a subclinical Cushing syndrome, and it is important to consider because they are potentially harmful. It's an ill-defined condition of altered HPA axis, the hypothalamus pituitary adrenal axis, in patients who do not have classical signs and symptoms of overt or apparent Cushing syndrome. And in recent years, it has become a topic of increasing interest and controversy. Now, this is because the diagnostic criteria are very heterogeneous and varied among the studies, and there are no specific signs for overt CS. So the commonest studies is the ONDST test, and failure to suppress cortisol secretion is considered mandatory out of the majority of these studies, but it is a cutoff point for a pathological EST, which is sort of an issue of discussion and controversy, and it can range from 50 to 138, but I'll not dwell a lot. But these are certain studies which I mentioned, which have taken different diagnostic criteria, but most of them would agree that low-dose dexamethasone suppression test or O9 dexamethasone suppression test is useful, but they have taken different cutoffs ranging from sort of 50 to 70, 80, and even 138. So these are all different cutoffs. But overall, it can be defined by the presence of increased urinary free cortisol. Now, urinary free cortisol is also a very good investigation that most endocrinologists would like to do. And unsuppressed serum cortisol levels after 1 milligram overnight dexamethasone, that is ONDST, low ACTH levels, and of course, no clinical signs of Cushing syndrome. So these are sort of criteria that are used in different studies, but at least 2 of these should be present to label a patient as subclinical Cushing syndrome. Again, different cutoffs, 5. And so, you know, if you take a different cutoff, the sensitivity and specificity would vary. And it depends on individual centers to stick to their own cutoffs. So we have talked about why workup of AI is important because the steroid-reducing adenoma is harmful and pheochromocytoma, of course, is a time bomb. Coming to the malignant, how can we predict whether a particular lesion is malignant or not? Oh yes, one more point. There are long-term consequences of subclinical Cushing syndrome because it has been shown that patients may be hypertensive, they have metabolic issues like diabetes, dyslipidemia, obesity, osteoporosis. So much so that there is a distinct impairment of quality of life as shown in different studies. And not only that, there is a certain increased mortality rate if these patients are not managed or operated. So coming to the second important question that we have to answer is that is a particular adrenal lesion malignant or not? Now, 2 factors have been taken over the different studies and over many years, which I also use in my practice, as one of the size of the mass and the other is a radiological finding. And it is conventionally taught that in masses which are more than 6 centimeters, 25% chances of malignancy is there as compared to 0% in masses less than 4 centimeters, but it involves the intermediate 4 to 6 centimeters that is questionable. This was a survey done in Italy, a multicentric study, which showed that the mass size is the most reliable factor in separating benign from malignant, and they took a cutoff of 4 centimeters. But the limit, if you look at these studies closely, you will find that these studies are limited by the fact that in most of these studies, old generation CT has been used, which has less resolution, so you cannot really rely on the exact size cutoff. And in some of the studies, it is not clear whether it was univariate or multivariate analysis. And in fact, interestingly, CT measurement was available only in 1/3 of the patients. And the hormone active lesions are not excluded. So there's a lot of heterogeneity in these studies. And this is compounded by the fact that there are now reports in literature that even adrenal lesions less than 4 centimeters may harbor malignancy. So certainly, definitely we need something more than the sizes alone to predict malignancy. And there comes the role of sort of these imaging studies where the Hounsfield unit is measured, and it has been shown that this is a very good criteria to predict malignancy. So two types of Hounsfield units are measured. This can only be done on real time. Most of our patients bring CTs out from outside where Hounsfield unit has not been calculated. So we have to ask for a repeat CT scan because the Hounsfield unit can be calculated only on real time and not retrospectively. So unenhanced values calculated as well as delayed enhanced is calculated. And in malignancies, if the delayed enhanced CT value is more than 30 or unenhanced CT is more than 20, then it is suggestive of malignancy. And there is a sensitivity of 95, but specificity of 100%. Now you can see there's a lesion on the right side top. It's a case of adrenal cortical carcinoma, which had an unenhanced CT value more than 20. Whereas the below picture shows a large myelolipoma, which is around 12 centimeters, but the CT Hounsfield unit were minus 40. So it was a diagnosis of myelolipoma. Again, just how to calculate, I'm not going into detail, but this is a formula where absolute washout is calculated, which is equal to enhanced minus delayed divided by enhanced minus unenhanced. And if the this delayed washout is less than 50%, because it is thought that if it's a malignant process, the cells are immature and they cannot process the contrast. Whereas if it's a benign adenoma, the cells can rapidly process the contrast and there will be a washout. So if the washout is more than 50%, the absolute washout, then it is diagnostic of adenoma. Where it is washout is less than 50%, it is diagnostic of malignancy. So although an unenhanced CT scan attenuation value of less than 10 is an excellent predictor of benign histology, but around 1/3 of adenomas are lipid poor, so they will not show a unenhanced CT value less than 10, they will have more. So therefore, and similarly, there are tumors which are less than 4 centimeters, but with Hounsfield unit more than 10, whereas tumors more than 4 centimeters may have Hounsfield unit of 10. So obviously, none of these criteria alone are very sensitive, specific. So the authors from Cleveland Clinic decided to have a combination of the two, where they combined the size with the Hounsfield unit, and they came up with a new stratification algorithm. And they said that if the tumor size is less than 4 centimeters, you give a score of 1, and if more than 6, you go a score of 3. Whereas similar scores are awarded to density less than 10, 10 to 20, and more than 20. And they found that if the score is sort of, they found that 1/3 of patients had a score of 3, another third had a score of 4, another third had a score of 5 or 6. But interestingly, the incidence of ACC in those patients with a score of 0 was 0%. And the score where Hounsfield unit was more than 20, it was 25%. So obviously, when you combine the size as well as the Hounsfield unit, you have a better sensitivity and specificity. So another advantage with this scoring system or stratification is that those patients with scores of 2 to 4 would have been spared a diagnostic adrenalectomy because the risk of malignancy is almost 0. Whereas a combination of size less than 4 centimeter and more than 4 centimeters and an attenuation value more than 10 will have 100% specificity to predict malignancy. So that is how a size and Hounsfield unit together can help the clinician to predict malignancy. Now coming to controversies, the first controversy is there any benefit of laparoscopic adrenalectomy, particularly in a patient who doesn't have an overt sign of Cushing syndrome, and is a case of subclinical Cushing syndrome. And nowadays, laparoscopic adrenalectomy is the standard of care, which is rather less invasive. The patient can go home the next day. Surgery takes less time. Potential herniation and all other complications post-operatively in long term are very less. And therefore, there is a tendency that there is a low threshold for adrenalectomy for patients with subclinical Cushing syndrome. Not only that, it has been shown in this beautiful review by Ecobone from Italy that the patients who were operated subclinical Cushing syndromes, they all had reduction in arterial hypertension, their glucose got better, the lipid metabolism improved, the body mass decreased in obese patients, the osteoporosis improved, and overall they had a good quality of life. So therefore, this cavalier attitude towards adrenal incidentalomas should be changed. All adrenal incidentalomas have to be taken very seriously, and they should be screened out to rule hypersecretion, whether they are producing cortisol, steroid, or methanol, catecholamines in the case of pheochromocytoma, or aldosterone in cases of primary hyperaldosteronism, or estrogen or androgens in cases of sex hormone secreting tumors. The third point is what should be the follow-up protocol for these patients. The American Association of Clinical Endocrinologists or the European Society of Endocrinology, usually it should be annual follow-up for 5 years. And no repeat hormonal workup is required if the initial workup was normal. Of course, if there is a development of new symptoms, particularly evidence of hormone activity, endocrine activity, then you can repeat the hormonal assessment. Now, this is an algorithm which is, I think, a beautiful algorithm for management of adrenal lesions. If you have an adrenal incidentalomer, the first thing is to do a a CT scan and look at the Hounsfield unit. If the non-contrast CT attenuation value is less than 10, then you go in for hormonal workup to see whether you can rule out a pheochromocytoma. So if it is less than 10, a pheochromocytoma is ruled out. If it is more than 10, then depending on the size, you will do estimation for the metanephrines for excluding pheochromocytoma. But if the Hounsfield unit is less than 10, pheo is excluded. You may not do a metanephrine. Just do a 1 milligram dexamethasone suppression test to rule out steroid-producing adenoma. And patients with hypertensive do an aldosterone-renin ratio. If it is non-functional, no routine follow-up imaging is required. Only hormone evaluation of 5 years only, particularly in tumors which are more than 2.5 centimeters size. If it is functional, of course, you will surgically remove them depending upon the etiology. On the other hand, if the non-contrast CT value is more than 10, and the lesion is less than 4 centimeters, do a DST, metanephrine, and ARR. Again, if it is non-functional, do a percentage washout at 15 minutes to rule out malignancy. If it is less than 50 to 60%, then surgery, because the chance of malignancy is more than 60%, and the size is less than 4 centimeters, I mentioned, then follow-up. On the other hand, in the patient's lesions more than 10 Hounsfield unit, more than 4 centimeters, again, you do a hormonal workup, including plasma metanephrine, all three have to be done. And of course, surgery is the treatment of choice. So this is the kind of rough algorithm that is followed by most centers with maybe minor changes, but I like to stick to this protocol for managing our adrenal lesions. So ladies and gentlemen, the take-home points could be that the incidence of adrenal lesions, especially adrenal incidentoloma, is expected to increase because of the wide availability of cross-sectional imaging. Remember, the commonest pathology of AI is pheochromocytoma and not steroid producing and non-functional. Almost to the 1/3 of your lesions would be pheochromocytoma. Very dangerous. So you can understand the importance of ruling out pheochromocytoma. Then the screening is done to rule out steroid producing adenoma as well as the primary hyperaldosteronism. The most important radiological characteristic is a non-contrast CT attenuation value, and this is very important. All clinicians, when they are asked for a radiology, please especially mention for the radiologist to calculate the HU unit. Again, a combination of adrenal size and attenuation value is very important. And if you have a lesion which is less than 4 centimeters with a non-contrast CT attenuation value less than 10 HU, it has 100% specificity for a benign adenoma, and you can follow the algorithm for the follow-up protocol in a conservative HU. Whereas surgery is indicated for most secretory tumors, whether overt or subclinical, and those with radiological features. So overt features, subclinical features, especially subclinical syndromes, subclinical Cushing syndromes, and those with concerning radiological features, they should all be operated, either by laparoscopic adrenalectomy, or robotic adrenalectomy, or you can do open adrenalectomy depending on surgeon's experience and the etiology of the tumor. So I hope I was able to share with you some of the important reasons why AI should be worked up very seriously, and they have to be taken very seriously because they have increased serious risk and mortality. Therefore, all clinicians, whether endocrinologists and endocrine surgeons, involved in the management should work up these patients on a set protocol so that we don't miss these potentially harmful adrenal lesions. Thank you, ladies and gentlemen, for patiently listening.